Hi everyone, welcome to week 7. This week we are on our chapter 7 and we are discussing enamel. So this will be our last lecture before break week. I know everyone is super excited, and just remember that your quiz will open today, and it is open till after break week. Okay, so if you don't have time to do it this afternoon, you don't feel that you have to do it on break week, I believe I have it open until the following Thursday. And then this is my niece here. This is Georgia. I think I showed you a picture of her last week. And this was when she was probably more so a year old in this picture. She just turned 2 years old a couple of weeks ago. So she has a lot more teeth than this now. And she's got a lot more hair too. So I'll have to get an updated picture of all of her teeth from my sister-in-law. Okay, so we'll get started here. So our learning objectives for this chapter are to describe the physical features of enamel, such as the structures of the enamel rods, incremental lines, lamella, tufts, and spindles. We'll also discuss how these will affect the permeability of the enamel and also the surface characteristics and the etching of enamel. Now, some of the topics that we'll look at today are the physical properties of enamel, the rod structure, the incremental lines, something called enamel lamella, enamel tufts, and enamel spindles. Also the surface characteristics of enamel, its permeability. So permeability basically means how it is able to absorb, how minerals and other components can be absorbed through the enamel, and also enamel etching. So this would be what you would know as the acid etch that we use when we are performing a Pitt and Fisher sealant. Now, an overview of enamel, just to kind of go over some of the basic functions of the structures of enamel. Remember that enamel is actually the hardest biological tissue in the body. So it is a very hard substance, meaning that it is supposed to be formed when it forms normally and accurately. It will resist a lot of the fractures during the stress of mastication. So during our regular functions of our teeth, of chewing, biting, clenching, that is how enamel is formed. It is formed to withstand that pressure. It also provides the shape and the contour to the crowns of our teeth. So the way that the enamel rods form, they form in different directions to form the shape of all of our different teeth. Because remember, anterior teeth have a different shape than our premolars and our molars and so on. Enamel is also that protective layer, so it's covering part of the tooth that is exposed to the oral environment. So we have this clinical crown that we can see when we look in the mouth, and then all of the other structures of the tooth, when everything is nice and healthy, should all be tucked away under the gingiva in the alveolar bone. So the enamel is made up of all of these interlocking rods. And you can kind of see just briefly in this picture here. We'll look at a lot more pictures that will be a little bit more clear, but enamel rods are basically this, this shape that you see here. It's also sometimes called or referred to as a keyhole shape. Okay, so it almost looks like the shape of a keyhole. And then these ameloblasts, remember those ameloblasts are the cells that are actually producing and depositing the enamel on the surface of developing teeth. So these ameloblasts, they're going to take different types of paths, and they're going to go and move around and bend in different ways and travel to different parts of the tooth to then make that actual shape of our teeth. Now, we're looking at a picture here. This is something called Hunter-Schreger bands. Now, this is when the enamel rods are actually viewed in what they call incidental light. Okay, so incidental light, basically what that means is when the light hits the surface of the tooth in a certain way. And this would be looking at it microscopically. Okay, so when the enamel rods are looked at this way, such as in this picture here, okay, you can see that there's these light and dark bands of enamel. Sorry, I meant to pick up my pointer here. Okay, so we have these light and then dark bands of enamel. Okay, and then here's another microscopic photo that shows it again. So light and dark, and it kind of goes all the way down. So those light and dark bands of all of the enamel rod groups are called Hunter-Schreger bands. Now, these rods, like I said, they're bending and twisting as they are laid down and deposited throughout the tooth. So as they start to make their way towards the cusp, and these two pictures here don't quite show the cusp of the tooth, but we will look at another one. But as they make their way towards the cusp, those cusp tips are, the enamel starts to kind of get all bunched together. And this is known as gnarled enamel. So gnarled is just another word for twisted. Okay, so imagine that up near that cusp tip of our premolars and molars, and even near the incisal edges of some of the teeth, that enamel is all kind of bunched together and gnarled. So that's how it gets that name. And then this is all going on and being deposited at very, very small, tiny little increments. So it's deposited at increments of 4 microns. Okay, so microns are extremely, extremely small. Okay, so just kind of for a comparison, if you were to take a strand of your hair, that thin strand of hair is about anywhere from 50 to 100 microns. And imagine enamel is being deposited at only 4 microns. Okay, so this is like very, very miniature or minute. Now these increments, as they are kind of being laid down, they almost look like the rings if you were to look at a cross section of a tree. So if you've ever seen that cross section of a tree, and oftentimes I remember learning when I was a kid that if you counted those rings, it would indicate how old a tree was. Okay, so these rings, these increments, they also have another name, and those are known as the striae of Retzius or the lines of Retzius. Now, these growth lines, they can sometimes actually become apparent on the surface of the enamel. They will look like little ridges, and the name for this is called perikymata. So in this picture here, you can actually see on this one, if you see these just very, very fine ridges that kind of go all the way along the tooth. So these are actually the growth lines. So imagine that this enamel is being deposited in all of these little increments, just slowly like the rings around the cross section of a tree. And sometimes it's actually visible. So you might even see a client, or even maybe look in your own mouth, and if you've got a really good light, you might be able to see these actual little perikymata, okay, so these little growth lines. Sometimes it's not visible at all, and over time with wear and tear, these areas might get worn down. So in this picture here, you can see the surface of the enamel is very, very smooth. Okay, we can't see any of the growth lines or perikymata, and that's just like any tooth. So over time, from normal chewing, eating, from erosion, those little lines can actually go away. Now there's also some small little gaps that will kind of exist in between these rods where crystals didn't form. Okay, so there can be these little gaps. So just like imagine if these were being these little layers or these little rings, but sometimes there might be these tiny little minute gaps. And this is what can make enamel a little bit variable in its density and its hardness. So if that enamel maybe had some type of, what's the word I'm looking for? Like a default in the way that it was laying its enamel down, and there were a lot of these little gaps, that might be an area that would be more prone to fracture because it wouldn't be as dense. Imagine something that's got lots of little spaces in between it. So these areas then could be more prone to being penetrated by small particles, and then that can lead to tooth destruction from caries. So if we've got these little gaps, imagine that those areas are areas that things can permeate through a little bit quicker. Okay, so imagine things like that are acidic being able to permeate an area that is has a gap in it. Now, after enamel is completely formed, no more enamel is going to be deposited. Okay, so once that tooth is fully formed, the ameloblast will stop depositing enamel, and the enamel does not continue to be deposited. Okay, so there is by the time we have our full clinical crown exposed, there is no more enamel that is being deposited. Okay, so our body stops to develop that, and the ameloblasts will be excreted. Okay, they'll go away. And again, so enamel is the hardest biological tissue in the body, and it is made to resist fracture during all of the stresses of mastication. Okay, so chewing and biting. Now, in saying that, this kind of sounds like it's contradictory, but it's also brittle, right? So even though enamel, yes, it is the hardest biological tissue, it's also brittle and can be subject to fracture. And really what this means is, so some of the things that we've just recently talked about, if there's any type of defect in the way that that enamel formed, and there are these little gaps that are forming in between the layers, those would be areas that could be more subject to a fracture or breakage. Also, if we have dentin that is underneath the enamel that has become weaker because it has a cavity, then that kind of weakens the support structure for the enamel that is over top of it. So that's oftentimes why a lot of people may not even realize that they have a cavity, because sometimes that cavity begins in between the teeth and it's into the dentin. That dentin starts to become really soft, and then all of a sudden a piece of the tooth might break off eventually. But if that doesn't happen and the client doesn't have any symptoms, they may not even realize that they have anything going on with their tooth. But remember that dentin, it is softer than enamel, but it's also a supporting structure for the enamel. So if that is underlying the enamel and it's been weakened, then again, that enamel is more subject to fracture or breakage. So hydroxyapatite is the crystal calcium phosphate that's also found in not only enamel, but in the bone, in dentin, and in our cementum. And then there's also an organic component of enamel. There's a protein that's called enamelin, and that protein, very similar to keratin, which is something that is found in the skin and in our hair. So enamelin is one of those other proteins that is going to help with the permeability of enamel. Enamel is originally actually a grayish white color, but it appears with that slightly yellowish color because it's translucent and the dentin that is underneath has a yellow color. Okay, so that is why some people, depending on how pigmented their underlying dentin is, and depending on how transparent their enamel has formed, they might have more of a yellowish shade to their teeth. Okay, so this is what happens when people maybe want their teeth whitened. Now the thickness, this kind of ranges depending on the part of the tooth. So it ranges from a very knife-like edge. So imagine really nice and tapered, like the edge of a knife at our cervical area, so right by the cervical margin, to about 2.5 millimeters of thickness over the occlusal and incisal surfaces. Okay, so that's where the enamel would be its thickest. Now we'll have a little bit of a closer up look at the enamel rod structures. Now, to form an enamel rod, it's actually made up of 4 ameloblasts. So remember that those ameloblasts are an epithelial type of cell, and they are columnar in shape. Okay, so picture that they are kind of like a little column, so they're a little bit longer. So there is one ameloblast that will form the rod head. Let me see if I can get here we go. Okay, so here is the rod head, and then 2 ameloblasts are going to form the neck. Okay, so the neck would kind of be like this longer portion here, this extension. And then the fourth ameloblast is going to form the tail. Okay, so this is known as the tail of the rod. And again, you can kind of see that it is a keyhole shape, and all of these rods interlock with each other. So they are nicely connected tightly together. Now the head of that enamel rod would be the widest or the broadest area. So that the head of the rod, so this portion here, the entire head, is about 5 microns thick. And then the tail, okay, where's our tail here? So the tail would be kind of more like this thinner area, and this is just 1 micron. But the entire rod, including the head and the tail, so the whole thing, is actually 9 microns altogether. So they are about the same size as a red blood cell. And again, remember when I was comparing it to a strand of hair. So a strand of hair, even though when we hold a strand of hair, depending on the texture of your hair, anywhere from 50 to 100 microns. But now we're looking at something that the entire rod is actually only 9 microns. Okay, so very, very microscopic. Now the rods are filled with crystals, and they are forming perpendicular to the DEJ, so perpendicular to our dentino-enamel junction. And each of those rods is actually interlocking with its neighbor. Okay, so it has a neighboring rod that it's going to connect to. And the reason why we want these enamel rods to connect to each other and interlock is because it helps to prevent the fracture of the tooth and to prevent the tooth from splitting. Okay, so they almost are like intertwined with each other so that they prevent any separation from happening. So you can kind of see, again, in this picture here, that the head of one rod kind of nestles or snuggles against the neck of the rod to its right and left. Okay, and this is exactly how they're all laid together. And then you can see, if we were to look at it microscopically, look how tiny. Can you imagine how microscopic this is appearing here? Okay, so at the cervical area, like I said, the rods are perpendicular. And at the cusp tips, this is where the rods become very gnarled, twisted, and intertwined. So this picture actually shows this better than our previous one. Here is our gnarled enamel. Okay, so imagine that the cusp tip is kind of all knotted, and this is where we've got this bunch of enamel that forms here. The surface of each rod is known as the rod sheath. Okay, so let's have a look here. So imagine the sheath is almost like the protective barrier around it. And then the center of each rod is the rod core. Okay, so I know this picture here, here's the rod core. It doesn't quite extend that line, but it's actually like this area, okay? Right in the center of the rod would be its rod core. And then again, those rods are going to bend to the right and to the left at different angles. And this is what is believed to actually provide the enamel with its strength so that it can withstand all of the forces of chewing and biting. So our teeth and the enamel can actually resist the mastication or the masticatory impact of around 20 to 30 pounds per tooth. Okay, so imagine how much force we can actually place on our teeth, 20 to 30 pounds. And now let's have a look a little bit closer at the Hunter-Schreger bands. So again, remember, these are those light and dark bands that are seen when light hits the surfaces of the enamel in a certain way or a certain angle. So these are named after actually a scientist named John Hunter, and he was the first one to actually note them microscopically. So that's why they became known as the Hunter-Schreger bands. Okay, so then again, this is just another microscopic cross-section that you can see the light and dark bands. Now we have our incremental lines. So remember our incremental lines, these are the growth lines or basically from the result of the depositing enamel that has been like almost, imagine it being deposited kind of in increments, but like with a certain rhythm to it, okay? Sometimes some of these incremental lines might even be more noticeable because there could be a little bit of a hesitation from the ameloblast when it is actually being deposited. Okay, so what that means is imagine that these ameloblasts are being deposited, and then all of a sudden in between one of those increments, there's a little pause. Okay, so that little pause might then have an incremental line that is more distinct. Okay, so that's basically what that means. And you can see from this picture here, really when you look, there's lots of different lines and some are a little bit more distinct than others. And that could be because of that rhythmic recurrent deposit of the enamel and that little hesitation or pause of the ameloblasts. Now, sometimes if there is this pause or this hesitation, then there can be a little bit of space that is between the crystals, and in that space it might trap some air molecules. And these are called accentuating lines. Okay, so another thing that could show these lines or accentuate them is this little bit of air that can get trapped in between them. So these growth lines, again, these are called the striae of Retzius, and they were named after a scientist who first discovered them called Dr. Retzius. Now in primary teeth, part of the enamel, remember it's actually starting to form before birth, and then part of the enamel continues to form after birth. So when we're looking at something that is has formed before birth, we're going to call that prenatal, and after birth would be postnatal. So due to the environment and nutritional changes that happen at the time of birth, there's usually this notable line of Retzius, so this more distinct line that scientists have seen microscopically, and it is called the neonatal line. So we can see in this picture, it actually shows it quite well. So here we have a tooth, we can see the dentin, and then we can see that this is the prenatal enamel that has been deposited. And right where this larger black arrow is pointed, it's showing this neonatal line. So it's separating. It's almost like there is this brief pause, and then when the tooth erupted, or sorry, when after birth, postnatal, we can see more of a distinct color when we're looking at the tooth microscopically. So the enamel before and after the neonatal line is actually of a different consistency. So the prenatal enamel typically has fewer defects to it, because imagine prenatal meaning that this is going on when we are still in utero, okay, so still in the uterus. But then postnatal enamel, this is happening after birth. And again, this is, like I said, this consistency is only able, you're only able to see this microscopically. Now, enamel lamella, these are actually tiny little cracks that are in the surface of the enamel. They will extend right from the enamel surface toward the dentino-enamel junction. This can be caused by lots of different things. So wear and tear on our teeth over time, caused by things like little stress cracks in the tooth. And these little cracks can happen when there are things like temperature changes, breathing in cold air, and then again, the temperature changes in the mouth because our mouth is more of a warm environment. Or it can come from drinking hot or cold beverages. It can also be from the stress that we put on our teeth from everyday wear and tear. So lamella, they're not actually defects in the tubules, okay, but they will appear like these little leaf-like extensions around the crown of a tooth. And they're actually very, very common. You might be able to look really, really close to your own teeth and see almost like, I always think of them as these little like hairline fractures in a tooth. That's what they look like. They're not technically an actual fracture, but they're like a little visible crack. Now, typically these are normal, and there's nothing wrong with having lamella. They are a normal part of the growth and the development of the teeth. But we do have to be careful. They can be little avenues for dental caries. So they can be more susceptible to permeating things, and they actually can cause a little bit of sensitivity too. So imagine things that are more acidic. They would be able to permeate into these lamella. Now the picture here is showing a couple of images, one microscopic, where you can see the where the lamella is, so it kind of looks a little bit jagged. And then on an actual tooth itself, it would look like this kind of little, like I said, hairline fracture. Now we also have this other really interesting structure called enamel tufts. And this is a developmental defect that actually is located right at the DEJ, and they form in right angles to the dentino-enamel junction. So in this picture, this line, this distinct line that we see here is our dentino-enamel junction. And these enamel tufts are these little extensions that kind of, they almost look like little puffs. Kind of think of them as these little like squiggly lines here, okay? So these are a natural part of the development of the teeth. And these little tufts, they're actually forming between the groups of those enamel rods, right at the scalloped junction of the dentin and the enamel. So basically what that means is the DEJ is kind of like a scalloped border to it. And then we will have these little enamel tufts. Then we also have enamel spindles. So these are more so like little finger-like projections. Okay, you can see these little pieces that stick up. And you can see the difference between these spindles and the tufts. So the tufts are kind of more squiggly. These are shorter finger-like projections. But basically these are actual extensions of the dentinal tubules that are passing through the DEJ into the enamel. So remember, our dentin is made up of our dentinal tubules. And if any of these pass through that little junction or this little barrier, then this is when we get something called an enamel spindle. So because dentin is actually forming before the enamel, the odontoblasts sometimes may penetrate that junction, and enamel can form around the process, which is then forming a tubule. So they actually think that these small tubules might be a living process of the odontoblasts and possibly contributes to the vitality of the dentino-enamel junction. Now they are usually found, they can be found just singles, like one by itself or one at a time, or sometimes they can even be in groups. So they're shorter than a tuft. The tufts, if you look back at the previous slide, they're broader and longer. Okay, and these are more finger-like. Now, this is just another good picture of our those fine ridges or fine lines called perikymata, or the imbrication lines. So again, remember, these are those little lines that may or may not be visible on everyone's enamel. And these are usually more prominent on the facial surfaces. So it's not often likely that you'll see them on the lingual, and they're typically closer to the cervical region of the tooth. Okay, so in this picture here, here's our cervical region of the enamel or of the tooth, and you're not really going to see perikymata at the cusp tips. It's more so towards the cervical margins. Okay, kind of see these lines. Now there's also a layer of prismless enamel. So what this means is there is a layer that is kind of structureless. So this is right on that outer surface of the enamel where the enamel's almost completed its development. It is the area that is actually quite thick. So it's 20 to 40 microns thick. In this area, there's going to be no Schrieger bands that are noted. So none of those light and dark bands. Okay, so this picture is showing this section here of prismless enamel. Okay, so you see that there's none of those light and dark bands like we see in this layer. And they are actually perpendicular to the enamel surface. Now let's look a little bit at enamel permeability. So of course enamel, although it is the hardest structure, it's important that it does allow the passage of fluid through it. We still want to be able to, this is how enamel will take in or accept things like fluoride and the minerals. So again, it allows fluid, bacteria, and bacterial products through it. And this can be caused from lots of different reasons. So the enamel might be more permeable if there are some faulty restorations. So faulty restorations could be an amalgam or a composite resin filling that is starting to maybe break down around the margins, and then leakage can happen, so that area will be more prone or more permeable. Also, when a tooth is starting to break down because of dental caries, and also those little pathways that we talked about and those other structures. So the lamella, so those tiny little fractures or hairline cracks, the tufts and the spindles, they might also be ways that the enamel is more permeable. Now there's also, I know we talked about lamella, which I said are those hairline fractures. There's also micro lamella. Okay, so these are actually, imagine these are even tinier, so like microscopic, okay, or very, very minute. So these are those minute spaces that are between or around the enamel rods and right through the crystal spaces within the rods. And then our enamel is also permeable because there are sometimes just regular surface irregularities. Okay, so there can be irregular areas on the surface of the tooth. If you think of areas of our teeth where our pits and fissures are, okay, there are certain parts of those teeth that might be more permeable to things that our teeth are exposed to. So enamel and dentin, they are both composed of hydroxyapatite crystals, and the crystals are larger in enamel than in dentin. Okay, so those crystals are actually 30 times larger, and this picture is just trying to basically show how large the enamel crystals are. So that size of the enamel crystals is basically related to the hardness of the enamel in comparison to the dentin. So imagine those crystals are much larger, so they're giving the enamel a much harder surface and much more prone to fracture. Now when we have our enamel etching, so this would be like our acid etch, and basically an acid etch is like a dilute acid that is going to etch the ends of the enamel rods. Okay, so that is really what our acid etch is doing when we are preparing a tooth for a pit and fissure sealant. So the rod core is actually something that will dissolve more than the rod sheath itself. And this is what is going to provide that adherence for our sealant material to stick to. So this is a good picture that's showing really how the enamel etching process works. So in our first figure, this is showing a picture of an enamel crystal. Okay, so just kind of like a diagram for you to see the shape of an enamel crystal. Now we have in B, the diluted acid etch would have been placed over top of the enamel, and now the enamel crystals are starting to partially dissolve. So this is what happens after we have rinsed our etch off of the tooth, and when we dry it really well and we see that chalky white appearance, then we know that the surface of the enamel has been properly etched. And now in figure C, you can see that this is showing the light and the dark areas after etching. So the light areas would be the areas where all of the crystals have been dissolved, and then the darkest areas are where the enamel crystals are still intact. Okay, so remember when we etch, this is why we're only applying it to these exact surfaces that we're going to be placing the sealant. We wouldn't want to etch the entire tooth surface. And again, it's not etching every single enamel crystal. It's only going to etch certain ones, because really what we need is that etch to basically kind of roughen up the surface. Imagine that now that some of these enamel crystals have been dissolved, now something's going to be able to stick to it better or grab onto it. And that's how our sealant material will retain much better if we've got a really good surface that's been etched. And now another important thing to note, there's lots of different agents that can actually penetrate the enamel and decalcify it as well. So things like lemon juice or any really like citrus or acidic type of fruit, sodas, all of those types of agents can actually remove the minerals from the surfaces of the enamel crystals. And then what happens is our saliva is also there to kind of counteract what's going on. So saliva has calcium and phosphate in it, and it's actually trying to maintain the pH in the mouth. But imagine if you've got a client who is consuming maybe lemon water every day, or they have a lot of acidity in their diet and they're drinking soda every day. Eventually, it gets really, really difficult for that pH to remain neutral in the mouth, especially if they are having these decalcifying agents on a very frequent basis. Now, again, those etched areas, they can be actually remineralized with sodium or stannous fluoride. So this is why we often will recommend after a sealant procedure that a layer of varnish is placed over the teeth as well. So if there's, let's say, perhaps any areas that were etched that maybe the sealant material didn't come into contact with, then we just kind of give it that little extra boost of remineralization by applying that sodium fluoride varnish to it. Now the fluoride ion actually does penetrate the porous surface, because remember that etch has now made the enamel more porous, and it's going to actually penetrate it and then help to remineralize. So this is why low levels of fluoride are really good, and they help stimulate remineralization. So the low levels of fluoride that are in things like our toothpastes, some of our mouth rinses, those low levels of fluoride on a regular basis, and for some clients who have a higher caries risk that are using it, should be using it on a daily basis, it really does help to keep up with the remineralization of the teeth. Okay, everyone, so that comes to the end of our lecture. And like I said, your quiz, I'm actually going to open it right now, so I'll open it up a little bit earlier. And I hope that all of you have an amazing and restful break. And I'll see everyone when they are nice and refreshed after the break week in week 8. Okay, have a good day, everyone.